Presenting a patient on rounds is easy as long as you know one thing, and it can be the difference between honors and a low pass. In this private coaching session, I work with a student who spent 2+ hours prepping for rounds. However, their presentations still felt scattered. She was exhausted, behind on self-studying, convinced that she needed to memorize more case details. Then I showed her how honor students actually structure their presentations. They prepare completely backwards from everyone else. Watch what happens when she discovers the one shift that transforms how attendings respond to every presentation that you give on rounds. Plus, at the end, I'll walk you through a quick challenge to see if you're ready to start presenting like an honor student. A team functions best when everyone is operating at sort of like as close to their level of training as possible.
Mm-hmm.
She said, if I can like run the labs, like, yeah, it's like scout work, whatever, right? But it's if I can run the labs and free up the interns' time so that they can do things that are more at their level of training, that means that the resident is also freed up to do things at more of their level of training because they don't have to like help run things. And then the attending can then do things that are more at their level of training. So like she was like, I have an impact on every single level of the team. And it starts with me just doing things that are just helpful. So I think that's just generally good advice. Okay. But that's like residents and interns. To be very honest, they just like, if you can do this, that's like, you don't have to do all the other stuff that you think that you need to do. You don't have to do.
Okay.
Right? Like, just ask yourself. So, like, do them, learn them at, like, to a reasonable level. But you want to follow the Parkinson rule, which is time will shrink or expand to fit the time allotted. So the time required to complete a task is. So in other words, if I give myself an hour to do a task, it'll take an hour. If I give myself 10 minutes, I'll figure out a way to do it in 10 minutes.
All right.
So like your pre-rounding or whatever it is, like think of the things that are taking the most time. Ask yourself, how can I do this in like 30% of the time? And you'll figure out a way to do it. Like you'll figure out what are the things that you can cut. And so, Cool. Make sense?
Yep.
So for attendings, there's actually like, I'm sure they want to go home too, but like they're not feeling it as acutely. And so for attendings, for the most part, it's you need to present without get good at answering pimping questions. For the most part, that's how. I mean, if you get to know them, like that also helps. But your sort of FaceTime with them is going to be much less, so you'll have less of a chance to sort of make an impression. Oftentimes, I think that the kinds of the impressions that you're going to make are like, can you present? Can you have good presentations, and can you answer questions? Like, can you answer their pimping questions intelligently? Doesn't mean you get the right answer, but at least like, can you do a reasonable job of answering it? To be honest, what you're learning in the course and what you're like, the way that you're studying you should already have noticed a difference.
Yeah, your lectures help so much. Like things actually make sense now.
Okay.
Reno was the worst before, but now I'm like, oh, it actually makes sense. I know what's going on. I know why this happens now. Magic.
And so it's kind of the same. So I will tell you that the other than people talking about like their scores improving and questions make more sense, I'd say the most common non-score feedback that we get about the program is that they feel so much more comfortable getting pimped, and they get really good feedback on like their clinical reasoning. And it's really obvious when like they're on a rotation with another medical student, because like the other medical student they're just like spouting facts and they have no idea what they're talking about often. So that, honestly, as long as you like, the more that you study, the better that this is going to get. Right. So pimping questions will improve even more the more you study. So like, again, if you can reduce the amount of time that you're spending on this stuff, it will help you even more to impress your attendings, because you're going to have more time to study because you work really hard. Right. And so the problem is I think you're working really hard without getting a lot of leverage from it. Right. Because you're doing like 100 things, whereas only maybe 10 of them are making a difference. If you just focus on those 10 or 20 things that are going to make the biggest difference, you would free up like 60% of your time to do other things. And part of that is going to be like sleep, which is also going to be a virtuous cycle, because now you're going to be able to study better and you're not going to sleep through alarm, do better in your self exams because you're not getting so distracted. right? In addition to that, because it sounds like you were maybe tired on your test. Is that possible?
I think I was. Both my neurology and psych shelves, like halfway through the exams, I was just like, I was zoning out. I was like, I don't know what I'm reading. Like, this isn't, like, I can't do this.
That
Like,
sounds
my
like,
reasoning was off. My
were
logic
you
was off.
were you really anxious?
I don't think I was anxious. I think I was just like, at that point, I was just like, I just want to get through this exam. That's it.
Yeah, either fatigue or burnout, but sleep is going to
Yeah.
help, honestly.
Okay.
Like so part of this is going to improve just because you're going to get more sleep, right?
Mhm.
Because again, you could probably reduce the amount that you're doing in the hospital by about 70%, and you could probably have 4 times as much time, right?
Mhm.
Like to do stuff because you're studying with very little time right now. And so if you just reduce the amount of time that you're doing on this other stuff, like
Mhm.
you could see a massive increase in the amount of time and
Mhm.
things you're able to do.
Mhm.
So that'd be the first thing. The second thing is so that's like the pimping will get better. The other one is like presenting without notes.
Mhm.
So are you presenting without notes right now?
I try. Depends on the patient. When I was on PTNT, I noticed that like during the second week I was on PCNT, I could like present most of the patients without notes.
Good.
But
When you
on inpatient was more complicated.
What's your feedback that you've been getting about your presentations from attendings?
I think one thing they're saying is that sometimes um on inpatient they're saying that a summary statement could be more complete, that I was not like including everything that I should have said.
Oh,
Um
okay. Or
on
too much information.
PCNT, I think on PCNT, I think it was fine at the end. Like toward the second week, I was getting a lot better. I was like able to just like say everything, like tell them all the physical exam findings, and my structure was getting a lot better. So I think the main thing was the summary statement.
Do you ever get feedback on like what's your feedback on like you included too much or too little information in the presentation itself? Like, oh, I wish that you had said that, or oh, that was like too much information. You didn't need to talk about that. Do you ever
I
struggle with that?
think I do. Sometimes they're like, "Oh, like, did you get information from? Did you get history about that part? About that information?" Or like, "Oh, did you ask about this? Did you ask about that?" Like sometimes I'll be like, "Oh, I actually forgot to ask about it." Yeah,
I see. Um, do you know the solution to that?
I don't.
So from a present and even in asking the question, this can make a big difference. Um, I'd say the single best advice I know of to help with
Mhm.
presentations is to begin with the end in mind.
Mm.
Begin with the assessment and plan when you plan. Does that make sense?
Oh, so like you mean like say like the summary statement first, like this
Oh,
assessment
sorry.
summary?
Like, oh no.
Like what do you
Uh,
mean?
so what I mean is, so for example, let's say that I'm going to argue that this patient that came in with shortness of breath is having a heart failure exacerbation.
Uh-huh.
I think that he has like he's cold but sorry, he's wet but warm, meaning like he's got good perfusion, but he's got
Mm.
like volume overloaded.
Mm.
I'm going to argue that he should be given Lasix, but he doesn't need to go put in the ICU or something like that.
Mm.
Okay, great. So I also need to explain why it's not any of these alternative things. So I need to explain why it's not COPD. I need to explain why it's not like
Mm.
deconditioning. I need to explain like all other stuff. And so I need, I also need to define the severity of the condition. So like, what's
Mm.
his exercise tolerance? What's his normal exercise tolerance? Like, what is it now? Is he
Mm.
having any problems with? But like all of these things become obvious that I should ask because I know what I'm going to argue.
Mm.
Because I think the most common mistake that I see med students or that I see med students make when they're doing their presentations is that they don't know when to say the thing or not. So like, should
Right.
I talk about
Mm.
their smoking history? Should I not talk about their smoking history?
Yeah.
Talk about their Hep B? Is this relevant? Is it not relevant? Should I talk about this? Right. And so the way to solve that problem is figure out like what are you trying to argue for? And what are you trying to argue
Mm.
against?
Oh, I see. Yeah.
Right. So if I'm arguing for heart failure and that it's like kind of mild to moderate heart failure, but not like severe, and I am arguing that like it's not COPD, it's not an MI, it's not whatever, right? Like whatever else would have been on my differential, then I'm gonna have to say like, okay, well, they did an EKG in the, like, so if I'm gonna argue against an MI, it's like, okay, well, they did an EKG, it was normal, and they did a troponin in the EKG in the ED. If I'm gonna argue that it's not asthma, then I'm gonna have to talk about like there's no wheezes, there's no like, he's no history of asthma, he doesn't have any like blah blah blah, right? Like it's just my presentation kind of writes itself as long as I know what my assessment plan is.
I see.
Does that make sense?
Yeah.
And then it also solves the problem of what question should I ask the patient in the first place?
Yeah, that's the thing. Yeah.
Right. Because it's like, because as you're writing the presentation, you're going to realize, oh shoot, I should have asked that. Or like, oh, I'm going to look up the ED course and let's see, did they report that they, have asthma, or are they taking an albuterol inhaler or something like that? Does that make sense? Like it helps you kind of cover your base.
So I guess my question is like, for example, like before I go to ask the patient these questions, like I should have like a picture of like what I'm gonna ask, right? It's more like, oh, I already have a differential at that point, or
in an ideal world, yes. So have you ever used the Hospitalist Handbook?
I have not.
You know what it is?
I heard of it.
If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260 plus scores. Click the link in the description below now to get instant access.
So it's put out by UCSF. So you've heard of like I don't know what color it is now, but Pocket Medicine. So it's like supposedly like the go-to guide for people for internal medicine. It's funny because it's written at MGH, but I actually never saw anyone at MGH use it ever in any department, certainly not internal medicine. And so what they use is what they call the white book, which is like, it's all the questions that you would need to ask, all of the labs that you would need to order, all of the management, like, dosing and everything. It's in like one very, very, very thin book. And you just carry it around in your pocket. And it tells you kind of everything for internal medicine.
Oh, wow.
Wouldn't that be great to have?
Yeah.
So the unfortunate thing is that MGH does not share it publicly. They're kind of like weird and stingy like that. But UCSF has basically their own version of it, and they do share it online.
Oh, nice.
So I'll show you, for example, like I think their heart failure chapter is quite good. So let's go to heart failure. So you see how it's like it gives you the definition. It's a clinical diagnosis, the syndrome, blah blah blah, right? And so classification tells you the classifications. It tells you the etiology, right? And then it tells you like what are the things you need to be looking at. So it's like, okay, great. So you need to look at an echo. And so even before you go into the room, you can be like, okay, let me check their last echo, right? And then you can also go through, right? These are the mechanisms. Okay, great. Blah blah blah. HFpEF is often associated. Okay, great. So this is how you evaluate it. So this is great. So you see, it's like these are all the things that you would need to do. Have you ever been like, you've ever go into the patients, done a presentation, they're like, oh yeah, what was the echo finding? You're like, oh God, of course, the echo.
Yeah.
Oh, yeah. That's like the worst. So in an ideal world, you're on internal medicine and you can use the Hospitalist Handbook because like that will like if it's in the book, it's like will almost never ever happen again for the things that are in the book. So they've got one for inpatient medicine, they've got one for outpatient medicine. So the nice thing is that like you can even kind of use it, like it obviously doesn't work as well for peds or family medicine or OB. Definitely doesn't work very well for OB. But like there's still some things. Like sometimes you'll still find overlap between them. And so it's still not a bad idea to consider the chapters. But for something like internal medicine, it's incredible. Like if you want to do well in your internal medicine inpatient rotation, outpatient rotation, you've got the inpatient and outpatient versions of this, and it's really, 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 really good.
So I'm just gonna follow this.
So just follow this. So what I would do with outpatient rotations is if it was in the outpatient book, I would like write down all the questions on my little like piece of paper that I would use to take notes, and I would just like have that available. Or I mean, you can also just it's now online, so it's a lot easier. So you can just print it out and just like literally just go and like kind of like,
just fill it out.
checklist style, be like, you
Yeah.
can come up with your own notation, but like X it out if it's not true, or like
Yeah.
check it if it was, or like, it's just so easy. So in an ideal world, you'd have that. If not, then the backup plan would be to begin with the assessment and plan of like, okay, like what do I think is the differential, and then just kind of go through the differential of like, and you can just kind of talk your thoughts out loud. Be like, okay, so you got shortness of breath. It's been happening for the last 3 months, and you're having an increase. So one thing I'm thinking about is heart failure. So I'm going to ask you some questions about heart failure, and then you go through. But I don't want to miss anything. So let's also, I'm also going to consider maybe there's like asthma, or maybe there's like, we call it COPD, or, emphysema, or something like that. I'm going to ask you some questions about this. And so you're just kind of going through your differential as you talk to the patient. That's the alternative. Obviously, it's not as good, but this is kind of something that's like kind of medicine. Like that's just what you do.
I do have a question though, because next week I'm on P's outpatient, and I'm going to be working with an attending directly.
Yeah.
So like, what should I do in that case? Like, I know that you were talking about this entire presentation stuff and like the pimping question part.
Yeah. So this is more for inpatient.
Yeah.
For outpatient, it's a little different. So for attendings for outpatient, the main thing, honestly, is don't slow them down.
Okay.
So whatever it is that you do, just like don't take an obscene amount of time with the patient and like slow down the. Because even the people that are like really understanding, like will still appreciate it, but there's like other attendings that are like not going to be very understanding, and they like will not like it if you slow them down.
Right.
So, that's the main thing. So you can just be upfront with them and say, hey, like I want to make sure that like at a minimum, I'm not really like slowing down your day. So like how do you prefer that I present? Right? Like you want me to just like take a particular amount of time, like just set a timer for myself, and like after that time, like that's it, like I just come on and present. Like how do you prefer this? Like what would make your day the best? Most people are going to appreciate you saying that.
Okay.
Right. So because they know it's hard. Like I actually, to very, very honestly, the rotations that I struggled with the most as a medical student were like very fast turnover outpatient rotations. Because you've got to get in very quickly, ask very pointed questions, go out, present without having to prepare. Like that's actually much harder than like an inpatient rotation where you've got like hours to think about how you're going to present it, and you can go and check the labs and go kind of think about it. And like outpatient, I found much harder. And so the best thing that you can do in that situation is if it's like a peds clinic, it's going to be a lot. Let's see, August. I don't know. I actually don't know. Winter is like
winter is pretty bad. Yeah.
Yeah, but I don't know in August.
Yeah, I don't know either.
The standard thing, but like in most of those kinds of clinics, it's going to be the presentations are going to be pretty similar.
Okay.
And so, that's my guess. So it's just kind of beating the attending and being like, okay, like
because on PZ&T, I was in the clinic a lot. I was in the outpatient clinic a lot, and then like I was really like seeing half of their patients and like presenting to them and write their notes. And I actually checked their notes history afterwards, and like most of them, like for most of those, like they just like signed it off right away. They didn't even change anything I wrote. So I guess that's a good sign.
It's a good sign, and I also think it's an indication of just again, like it really emphasizes like don't slow them down. Because they're trying, like, they are just trying to make sure that because like most of medicine, they're paid based on the volume of work that they do. So in a clinic, they're paid based off of like the volume of patients and the complexity of those patients. But volume is a big part of their income, honestly, if you think about the math of it. And so what that means is, like even if they're not driven by monetary gain, the clinic at some level is. And so that's why they stack, like there's always more patients to see than they probably should be seeing.
You see like 30 patients a day. I'm just like, how?
It's crazy. It is so crazy. So
I don't even remember everything. Like it's impossible.
I would argue that in many ways, it's actually you kind of want to treat them like residents and interns in that case.
Just be helpful, yeah.
Just be helpful. Like say like what would
Yeah.
be, what is like,
Mhm.
and you can just say that like I have so much respect for what it is that you're doing. Like
Mhm.
what just tell me what it is that I can do to be like as helpful as possible. And
Mhm.
I know that I at this stage in my training, like there's so much that I can learn doing anything. So,
Mhm.
if it's progress notes, if it's, like whatever it
Mhm.
is, like let me know.
Okay.
And if they really care about your education, they might push back. If they don't, and they just want like either way, you're
Okay.
not going to be saying something like that.
Okay.
Like, just solve their problems. Like if that's all you remember from this is like figure out what is their problem, put yourself in their
Mhm.
position, solve their problem
Okay.
for your clinical grades, for interviews, residency, for like whatever it is. That is because it's something that because to be very honest, to get to this point, you've kind of had to, people have kind of had to be selfish. Like you've got to focus on
Yeah.
your grades, your research, your, whatever. So
Right.
it's like you've it's not only been selected for, it's been encouraged by the system. What that means though is that it doesn't take that much for you to stand out by being thoughtful towards others.
Mm.
Because no one like it's like you're in a population of people that is not.
Yeah. I agree. I totally agree. Yeah.
So that's what I would say.
Okay. I'll follow
What are your
this.
sorry?
I'll just follow this.
What are your major takeaways from our discussion today?
I think just I learned how to like use my time wisely in this busy schedule because I just felt so tired, so exhausted without getting, what I'm supposed to get. And hopefully by changing this strategy, um, I'll have more time for studying, and then I'll see improvements on the shelf and exams overall. And just higher efficiency studying because I will not be that tired. I'll be able to focus better.
So are you ready to present like an honor student? You can be, just by mastering these 3 presentation skills that actually matter. First, begin with the end in mind. Start with your assessment and plan, then work backwards. Your differential should drive pretty much everything else. Number 2, show your clinical reasoning. Don't just state the facts, but walk your attendings through your logic and explain why it is this diagnosis and not the others. And finally, present without notes. This is the ultimate flex. It shows you truly know your patients, not just their charts. Master these 3 things and you'll stand out on every rotation while actually getting more sleep and study time. Honoring a rotation isn't about memorizing more, it's about thinking differently. If you want to see how that same shift helps students go from failing to scoring 260 plus in step 2, watch this next video. I'll walk you through the exact step-by-step system that guarantees 80 or even 90% correct on every topic, using the same reasoning framework that top scorers rely on. Click here to see how one student went from failing practice tests to scoring in the top 0.5%.